All right. So good afternoon, everyone, and good morning to those joining us from the West Coast. My name is Hamira Osman, and on behalf of Muscular Dystrophy Canada, I'm very happy to welcome you to our webinar from our new Let's Talk NMD, Let's Talk Neuromuscular Disorder series. Before I introduce today's topic, I would like to mention that we have muted all participants, but I welcome you to type any questions or comments throughout today's session in the chat box. We have allotted time at the end of today's webinar for a live Q&A. I'd like to also note that a recording of today's webinar will be available by the end of the week on our MDC YouTube channel. With that said, let's get started. So today's weekly webinar is on patient, client, and family engagement. At Muscular Dystrophy Canada, we recognize the importance of enabling clients to participate in their own care in navigating difficult situations outside of healthcare and in helping to inform our programs, services, and the policies we advocate for. To speak more about our client-centric approach to delivering our mission, I'm very happy to invite Stacey Lintern, Interim CEO at Muscular Dystrophy Canada. Stacey joined MDC in 2012 and has held various positions, including Executive Director for Ontario, VP Mission, and most recently COO. During Stacey's tenure with MDC, she's had oversight over the delivery of the mission nationwide, annual campaigns, and the firefighter portfolios. Stacey's worked in the not-for-profit sector for over 20 years. She has worked as a senior manager in large health organizations where she managed organizational development, strategic planning, stakeholder relations, partnerships, and mission delivery. She's also provided consultation for government with a focus on crisis management, accessibility policy, prevention of abuse for vulnerable populations, as well as access to healthcare. We're very happy to have Stacey talk about MDC's client-centric approach. Stacey?
Thank you, Hamira, for that introduction. And I'm so pleased to be here sharing some information with you with regards to Muscular Dystrophy Canada's commitment to a client-centered focus and approach. It's such an important subject. So we can go to the next slide, please. In 2012, Muscular Dystrophy Canada conducted a comprehensive assessment to better understand our clients' needs. We traveled coast to coast and met with several key stakeholders, including persons with a neuromuscular disorder, family members, clinicians, volunteers, to better understand what our clients' needs were and how we could address the gaps and not duplicate services from other like-minded organizations. Some of those common themes that were identified were really crucial in terms of our planning for our strategic plan and our overall development for our organization. Everyone's experience is unique. Our clients taught us that a neuromuscular disorder does not define who they are, that our clients are dynamic, they have aspirations, goals, dreams, challenges, and as well as successes. They also taught us that their goals are important. Goals are personal, unique, and that they require information and confidence and support to achieve their goals. You can go to the next slide. Thanks, Hamira. Our clients are and continue to be the center of our organization. We ensure that our clients always have control. Our clients make informed decisions based on their own preferences. We respect our clients' decisions and values. We don't make assumptions. We don't make judgments. We listen. We provide support to the whole person. That includes the physical, emotional, and psychological. Our clients deserve a prompt response. We know that our clients have unique needs, diverse needs, complex needs, and require a prompt response. Our clients define their own goals. Again, personal goals. They're not our goals, they're their goals. We work with them to know where they're at and meet them every step of the way. When they're ready to proceed, we'll proceed. We're constantly reviewing our provision of mission delivery to meet our clients' diverse and ever-changing needs. We know that this is important. We know that this, in terms of our programs and services, it's not a cookie-cutter approach. We know that we need to be progressive. We need to offer diverse programs and supports within our mission, and again, meet our clients where they're at every step of the way. One of the testimonials that were provided through the consultation process was a common theme that we heard, and this is an example of one of our clients with Muscular Dystrophy Canada, and they were clear to share, my neuromuscular disorder does not define who I am as a person. I have goals and aspirations. Sometimes I need help attaining them.
Thank you very much, Stacy. Next, we have Laura Williams. Laura is the Director of Patient Engagement at the University Health Network, and she oversees patient relations, patient education, My UHN patient portal, interpretation and translation services, and the patient partnership programs. These teams support the role of patient engagement and organizational decision-making, and at the point of care. Laura has held patient engagement roles at Health Quality Ontario and the Holland Bloorview Kids Rehabilitation Hospital. Laura also has a son with a rare genetic neurodevelopmental condition called GRIN1. His diagnosis at age 9 through whole genome sequencing has led to partnerships for the advancement of research in GRIN disorders. And last year, Laura's family co-launched the CureGrin Foundation. Welcome, Laura.
Thank you. I'm just going to do a quick check on my sound. Are we good?
We are good. Yep.
Okay. Excellent. Thank you so much. Really happy to be here today. Thank you for the opportunity to share a little bit about what we do at the University Health Network around person-centered care and partnerships. Truly that, the end result there is a better experience, hopefully, for our patients, our clients, and family caregivers, as well as our healthcare providers. Next slide. But as was mentioned in my bio, I also come to the role with my own experience. And this is my son, Bryson, and Bryson is 13. He'll be 14 in the summer and a full-blown teenager. Bryson has a neurodevelopmental condition called GRIN1 and was diagnosed at the age of 9. So he does have low muscle tone, developmental delays, as well as kind of cognitive and speech delays as well. But over the past few years since getting the diagnosis, my family has been on the path of partnerships for ourselves, so meeting with researchers and others. And if you go to the next slide, I just wanted to share that we have actually documented some of our experience with patient partnerships, and I share that because we do go through the piece around meeting with researchers, understanding and getting to a diagnosis, developing mice models, and then launching CureGrin. And this is my husband's podcast, which was launched through the CBC just 8 weeks ago, and the final episode was launched today. And so, if at any point you're interested in hearing more about our research path and journey and our journey of discovery around Bryson's condition, I would certainly recommend that you tune in. I'm really proud of my husband and the work that he's done to develop this and share this more broadly. But really what we're striving for when we talk about patient partnerships, and I reflect back on my own experience, and then when I'm in my work mode, again, then it's not about me, and it is about how do we ensure that patient and client voices and family voices are at the center of what we do. And so I'm sharing with you a quote from Germaine. Germaine is a patient partner at UHN. And the key to this quote really is at the end there, where he talks about every moment, every exchange is an opportunity for us to improve healthcare. And when we empathize, we empower. And I was asked to talk a little bit about the research behind patient engagement and why it's so important, and why person-centered care is so important. And what I want to reflect on is that the literature really tells us that one of the best ways to create empathy is to use stories and lived experiences. And that is a key part of patient engagement and patient partnerships, when we do kind of get out there and share our stories for the public to hear, for providers to hear. then we are able to then shift and create a deeper sense of empathy and opportunity for others to listen. And in terms of the research, actually, there is some evidence out there that is through MRI imaging that says as the listener of a story, our neurochemistry actually lines up with that of the storyteller. So it's not just an idea that when we hear a story, we can understand and relate more, but in fact, there's evidence to demonstrate that. And it's also how stories stay with us so much more strongly than simply hearing a fact or a piece of information. And so when you have an opportunity to get out there and share your story, all the better. And so with the slide that's up right now, this is a bit of a description and shows how we can share our stories, our lived experiences, so others can learn and hear from us. And whether that's through direct care and really putting our whole selves out there and asking questions, or engaging with the organizations that we are impacted by, that we're part of, through organizational design and governance and policy making. Many organizations now have patient-client advisory programs and panels, and they are looking for different ways to engage those who they serve. So either through consultation, by sharing information and getting some feedback, involving clients directly at the table, or then really developing and co-designing work. And I heard a lot of this initially. Looks like MD Canada is doing a lot of great work really around the partnership and shared leadership and shared decision making around organizational design and policy making of the organization. And so why do we, and I should just reference the model that I have here is the Carmen model, and lots of great references to that framework for engagement more broadly. And on the next slide, you'll see that, why engage and partner. And this is a slide I use when I talk to healthcare providers, but I was asked to talk a little bit about the research with you. And for those of you who have lived experience, this will all be very intuitive. And it's helpful though, when you're trying to advocate for a place at the table, to be able to use the language that aligns with your listener. And here are some of the reasons why, when I am encouraging our organization or others to have clients and families at the table, what are some of the benefits and why should we be doing this? And so we talk about a reduction in errors, that more informed patients and families through, even measuring our patients and how they're activated in their care is important. That's one of the key ways in which we can reduce errors. Setting priorities together and establishing the priorities and reducing and removing our assumptions about what is important to patients and families really creates an efficiency that is very different from healthcare organizations and providers making their own decisions and then having to kind of reinvent the wheel and go back because we missed a key and important part of what is a priority for a client, a family. And unless we have clients, families, and providers all working together at the table, we're missing that very important and very key part of what direction we should be taking and how we should focus really our efforts in care, our efforts in organizational decision making, as well as in research. And then on the next slide, this is more from my context, but I think it's an important study to reflect on, because a lot of providers are quite shocked actually when I tell them this. But many of you may not be if you've been hesitant to voice concerns. And I know this is the work I do every day, and yet when my son or my parents or another loved one is in care, I too have a challenge speaking up, because we know that our loved ones are more vulnerable, that we really need these relationships with providers. And this one study of over 1,000 people showed that 50 to 70% were hesitant to voice concerns about possible mistakes in care, mismatched care goals, confusing or conflicting information, inadequate hand hygiene. And it was comments around, I don't know what to ask, I don't know how, maybe the team is too busy, I don't want to be a troublemaker. And when I talk to providers about this, it's a bit of an eye-opener, because what we're encouraging them to do is say, what questions do you have? And they want to hear those questions, and they do want to kind of invite that dialogue. And sometimes it's a matter of slowing down just for a minute to be able to hear and see the individual in front of you. And so what's important about this study is that none of these, mistakes, mismatched care goals, none of these are all essential parts of care. None of these are kind of light-hearted questions or concerns. These are key elements of keeping everyone safe and working together. So it's important for us to bring up our concerns and bring it forward. And there's kind of many different ways that we can do that. And it depends on your experiences. It depends on who your providers are, but how as clients and families and participants in care, we can be the most proactive, that we're taking our care into our own hands to the greatest degree possible. And truly, there's almost an inverse of education there that happens when we are able to bring this forward. And there's many ways to participate in care, and looking out for things like patient, client, and family libraries or resource centers. Many of these have reliable health information and can provide personalized information. As I'm sure you're aware, there are many settings that the information you look for is not always reliable. And we're definitely seeing a lot of this with COVID right now, where there is far too much information out there and much of it is conflicting, and it becomes very challenging to know where to go for the most up-to-date information. And so looking for sorry, my sound is doing something funny here. Not sure if that's any better. But looking for a few sources of credible information is really important. Second, our patient, client, family portals. So do the health organizations that you work with have health record access online? And really reviewing that information to ensure it's accurate, and if follow-up is needed to do that, because that's really what providers would be looking for and hoping for. Unfortunately, mistakes are made, and we see it far too often. And so again, on a client side, not making the assumption that everything is accurate and correct. And unfortunately, we know we have to take those moments and review our care and advocate when we do see discrepancies, changes there. And then in terms of participation in care, there are virtual care options now. With COVID, we know that there's been a significant shift to virtual care options through many organizations, and sometimes it's through teleconference, sometimes it's through video, but asking for that as an opportunity, as an option for you. And the hope is that going forward, we will have these as options that are more available. Things that we've been talking about for 10 years, I've seen change literally in about 6 weeks now, in terms of virtual care appointments and getting people the access that they need in a much more efficient way for patients, not for providers. And if you do happen to have a loved one in a residential setting, asking for patient and family connections, so iPads, teleconference, and other ways. And finally, in terms of participating in your care and shared decision making with your providers, write your questions down, take notes, bring someone with you when possible. Ask who you can call if you have follow-up questions after you leave. This for me is always so concerning. So many of our patients, our clients, leave the organization, and then when they do have a follow-up question, they really don't know who to call. Is it their primary care practitioner? Can I call back to the unit if I have a medication question? Just asking those questions in advance, and the more that we can develop those resources in our organizations, the better. And posing those questions, if you are at a table that is developing resources, is helpful. And then finally, ask yourself, what should I tell my healthcare providers so that they understand my context? Providers are busy, and so are we. And so how do we, as individuals, also talk to them about what's important, what are our priorities, what is our context, and how much can we manage and how much can we not manage? And so I just wanted to share with you one tool that we are using at UHN on the other side, where we promote the use of TeachBack for providers. And something we're exploring now is also client-initiated teach-back. So essentially, it's just show me or closing the loop. You know, patients repeat back their understanding of the diagnosis, test results, treatment protocols, and next steps, and really confirms mutual understanding. So a way to do this is with the provider. You've been given information, just basically saying, can I just share with you what I heard to confirm that I understand what you were saying and that I have all the information right? It also helps, I know for me, I will think I have all of the information in hand and I go home and immediately I'm questioning what it was, what exactly those instructions were. It also is a great tool for helping clinicians understand over time the best way to communicate with patients. And so they learn when, you know, when they're communicating and then the information is not getting through clearly, they learn over time how to kind of readjust and how to message things in a different way. So much of this I've reflected on is what, you know, clients and patients can do and families can do. From an organizational side, we're, you know, working hard to ensure that hopefully all of that is not necessary if we're being proactive. The more we can do together, though, the better. And so talking about how to become engaged and take an active role in organizational decisions and research, you know, if you have the energy, if you have the time, is a great way to ensure that organizations are going to meet your needs, meet the needs of other clients coming through the system. And we sometimes have capacity and we sometimes don't, and making that decision. And so things to look out for is, does your organization have formal advisor roles or an advisory body that you can participate in? Really thinking through what's your greatest area of interest. You want to be doing something that's of interest to you, that you feel connected to, and consider all of your experiences as helpful and think through a broad range of your experiences before meetings. You know, there's so much that you can bring to the table, and bringing, really thinking through your experiences and the kind of key areas that you would like to see changed. And sharing those stories, as I mentioned before, is really helpful when we're trying to kind of make sense of a topic as a healthcare organization. All of a sudden, patient perspectives make it really crisp and really focused. Ensure you have a point of contact to help you prepare for meetings. That is best practice. It's not always done consistently. And researchers are often required, so just something to be aware of, researchers are often required to include client perspectives in the development of proposals and have a lot to learn from you. So something my husband and I noticed when we were kind of connecting with researchers and biotech companies was that there was no hesitancy on their part to meet with us. They were keen, they were interested, they had a lot of questions for us, and they wanted to learn more, and we're open to shifting some of their research priorities and research questions based on what they were hearing from us. And many of them, I mean, our disease is rare, but many of them had never met someone with our son's condition, and just making that personal connection is a real driver, I would say, especially for younger researchers who may not have had that exposure in the past. Yeah, so I'm going to leave it there, and thanks so much again for having me on this important panel.
Thank you very much, Laura. I really appreciate it. Next, we have Bonnie Wooten. Bonnie is the Shared Decision-Making Project Lead and Decision Coach at Children's Hospital, London Health Sciences Centre. Bonnie offers a supportive, neutral, and non-directive process by providing coaching face-to-face on an individual or group basis, by telephone, email, online, or through telehealth. She facilitates access to evidence-based information, clarifies decision, and monitors patients' needs. She helps to verify understanding, clarify values, build skills in deliberation, communication, and accessing support. She helps to monitor and facilitate progress in decision-making. We're really happy to have Bonnie here today to talk about shared decision-making.
Thank you very much. I'm really excited to be here and have this opportunity to share this information and this pathway with families and healthcare providers, which I'm thinking are and hoping are on this webinar. It is a process, it is a service that we offer at Children's Hospital, London Health Science Centre. I also want to acknowledge Dr. Craig Campbell, who is the initiator of the project and brought this to Children's Hospital. We are the only pediatric hospital in Ontario that is practicing this service as as I will describe to you as we get through the slides. But he isn't able to join me here, but he may be on the webinar listening. So what I hope to do over the short term here is talk a little bit about what shared decision making is, give you some context, what the evidence is, a little bit about the process, how how decision aids and coaching is utilized and how you can access this service, how families have responded, and kind of end up with what has been the impact over the last 2 years since we've been supporting this and providing this service. So, Humira, if we could go to the next slide. Just to start with, so what is shared decision making? I'm sure that people have gone to various sources and have heard a lot about shared decision making depending on what context you're in. So it is the process whereby health professionals and patients collaborate on medical decision making with a more structured process that takes into account both the best evidence and patient values. Shared decision making has been shown to improve compliance with treatments and decision satisfaction. I'll talk to you a little bit about the evidence around the statements in this little tutorial. Ottawa Children's Hospital are the leaders in the model that we use. There are some differences with our model, which I will share with you as we go through. So go to the next, thank you. It really very basically, to take that context of that short description and share with you that it is a partnership. Shared decision making is a partnership between the clinical choice and the patient choice. We know that healthcare providers are the expert on the disease, and we know that patients are the expert on the patient, on yourselves. Can we go to the next? Shared decision making is a commitment to patient and family-centered care. It supports the families in gaining treatment options, knowledge, evaluating benefits, what the harms or the drawbacks are, and clarifying their priorities. It supports physicians and healthcare professionals, that should be both, in delivering evidence-based care, hopefully avoiding legal and ethical challenges and managing time. Now we know that when we think about the healthcare provider, they can take a paternalistic approach sometimes to providing to their recommendations. And we know that they have a flood of knowledge information, and that's what they share with the families, and may tend to drift a bit away from the evidence, which shared decision making brings back into the pathway. We know that healthcare providers also are very busy, and sometimes they can disengage. And with shared decision making, having a decision coach, you can have someone designated just specifically to spend time with the family, to go through those evidence-based decisions and look at their options, look at how they value those options, and improve the way they approach their decisions. We also know that the patient can be, if we just wait a bit, the patient can be consumeristic in their approach as well. They know how to access knowledge, and I think this way with shared decision making, we can give you validated information that will be evidence-based and relate to your situation. And sometimes the patient can and families can become a little bit passive because they know that they've been given information from the healthcare team that can be overwhelming, and they just don't know where to go or what to do. So that's the next one now. What is the evidence? So you're thinking, like, what is the evidence around this? The Cochrane reviews, if families and healthcare providers would be familiar with Cochrane reviews, and they keep them pretty up to date. So I have the last one as to 2017 here. You can see that with what the evidence shows that for the patient, this shared decision making increases their knowledge. They get more accurate risk perceptions. They have a greater number of decisions consistent with their values, and it reduces the level of decisional conflict for patients, and fewer patients remain undecided and unengaged through this process. With healthcare providers, they have better patient-practitioner communication. And that's because through the process, we work with the families to try to strengthen their skill set so they know how to go back to the physicians and talk about what their recommendations are and what their preferred decisions are. And for healthcare professionals, there are no harms and it's not time consuming for them when there's a decision coach involved. With the healthcare system, more cost effective, may improve overdiagnosis and overtreatment, which I'm sure that lots of families can relate to that. Many patients actually choose less invasive and less costly actions, maybe not surgery, maybe a less invasive recommendation, appears to reduce practice variations and can alleviate differences in decision making for the lower social economic. So can we go to the next slide? Before I go into the coaching, decision support coaching roles, I wanted you to see this framework that's from Stacy and all, again, from the CHIO decision-making group. And as you can see, it's very nicely laid out so that you can understand how the decision coaching is going to work. We have the patient role, who you identify and communicate your informed values and priorities shaped by social circumstances. That's sort of kind of a high-level statement, but the whole goal behind decision-making is informed decision-making based on the patient's priorities and values. So with the primary role for the clinician or the healthcare professional is to diagnose the problem, discuss the options with the family, patient and family, and screen for decisional conflict and refer to the decision support. With the coach role, I'm going to go through that a little more specifically, but just to give you in this framework, it does prepare the patient to participate in decisions, and that's what's key in family-centered care, is to have you involved in, as we just heard on the previous presentation. This fits in really nicely. The decision coach role can assess decisional needs and assess your decisional conflict, what your level of knowledge is, clarify your values, and what kinds of supports you have. And providing decisional support can be tailored to your needs, not what you would go if you went to Google. I call it Dr. Google, but it's try to keep you away from that, because you would get a general, get general information. And what the decision coach role does is they tailor the evidence-based information to your needs, specifically to your needs and your diagnosis. And we monitor and facilitate your progress to try to resolve the needs and the quality of the decisions you're making. And we also do some screening for implementation needs. If we could go just to the next slide. So based on that theoretical support role that we just went through, what is decision coaching? It is structured assistance, which you heard me earlier say. It is a structured assistance provided by a decision coach outside the patient's circle of care. So you say to yourself, why outside the circle of care, and why is that important? It is important because it reduces the bias. As a decision coach, I'm not privy to the recommendations and discussions that the families have with their physician, or their healthcare professional. So all that gets discussed with the family. When I come into the coaching, into this pathway and meet with the families, I am non-biased. So this reduces the level of conflict and encourages the families to participate more openly in their options, because I wouldn't come into the consult with one option. We would come into the consult with looking for the family to be presented with, here are all the options, and what do you value most, and what works for you, given the risk, benefits, and the harms of each of those options. It does, we develop your skills, the family skills about the options, and prepare you for the consultation and what would happen when you go back into your meeting with the specialist or your healthcare professionals, should you choose not to go with their recommendation. Again, as I mentioned, it is tailored to the patient's decisional needs. As a facilitator, I am in a position to be supportive and non-directive. I do not make the decision. I facilitate the families in helping them make the decisions. I always say to the families, it doesn't matter to me what decision you make. It matters that you were able to participate in a decision, a preferred decision that fits you and your family's needs at this time. It does aim to achieve decisions that are informed. And that's why with the decision aids, they're specifically set up for you and based on your values. We deliver this coaching, or I deliver the coaching. I do it a lot face-to-face, some by telephone, although that's more challenging, but I do some by telephone. And telehealth is pretty prompt. It's one area, it's one method that we're using a great deal of now because of COVID-19. And I'm finding actually that doing OTN consults are actually, there is an edge to being better than the face-to-face because the family's in their own home. They are comfortable, they're in their own environment, they're discussing it more, it's less invasive because they're in their own environment. So it's been quite interesting to see the responses to families and how anxious they are to work from their own environment. We know that choosing between alternatives can end up being really nothing. You might choose between alternatives and you might decide to do nothing. We know that most healthcare decisions have no clear best choice. And I'm sure many of the families and healthcare professionals go through this all the time. But as competent decision makers, and everyone makes decisions every day, I really want to impress upon the listeners that this does not take away from what you do with your families or families, decisions you make every day with your families and your support systems. It is just another pathway, and it is an adjunct to what you currently do. So this is offering another pathway to give you one-on-one support, give you the time that you need to make decisions, and look at all the benefits and the risks and harms. For one of the pieces that's very key to assisting us with this process are decision aids, what we call decision aids. They are interventions designed to help people make specific and deliberative choices. They make explicit the decision. They provide information on the options and the outcomes that are relevant to the patient's status. They clarify personal values and intended as adjuncts, as what I just mentioned, to counseling. It's important for you to know that the patient decision aids are different than patient education materials because these aids are personalized to fit that individual and the recommendation that's being made in the decision that you have. And they're set up to encourage your involvement rather than just to explain what the information is about the disease and what the management of that disease is. Go to the next slide. And so these are decision aids, some format used with consultations. The decision aids can be in print. They can be through DVD and videos. They can be online computer-based. So they come in various formats that are very helpful with families depending on their learning needs. If we go to the next slide, this is another tool that we use from the CHIO Shared Decision Making Group. It is called the AutoOff Family Decision Guide. I use this in my consults all the time. It is an excellent tool. It really, you can see the readability of the example in there is small, but there is an example in there. And as you can see, it allows for the families to look at various options, and it includes the child. There may be children who can be part of the decision making and that are in a position that the parents are in agreement that they can be decision makers on their own, or they can join the parent in being a decision maker. And certainly when you look at this tool, it outlines, it provides the opportunity for pros and cons and weighs the importance of, if you chose this option, what would that look like to you, and how would you value that option? It also looks at how you value the option. What level of knowledge do you have? What supports do you have? What level of certainty do you have? And the supports are very key here. Like, do you have other members of your family that are involved? Do you have distant relatives? Are you and your partner not living under the same roof, but you're both engaged in the care of your child or your children? We do get a fair number of families who are separated, but engaged in the care of their families. So this allows for everyone to have some kind of involvement and engagement. We go to the next slide. I thought it would be helpful for you to get, as part of the context, to see what kind of populations that that referrals might be ideal for. And many of you have been in these scenarios where it's a complex decision, faced with potential conflict and stress. You just can't really get to that decisional point. There's always quality improvement processes for adapting the evidence and best practices to support patients. Our epilepsy program in pediatrics has a program going where the decision coach is part of the process that helps families work through their decisions around invasive surgery for their child. Situations of non-compliance. If you're wavering, you have delays in deciding whether you want to go this, you just can't come to a conclusion. Multiple healthcare professionals are involved with your care, each who express differing opinions on treatment options. Households where differing opinions on preferred treatment options exist. Families with so low social economic status or their language barriers. And we have a few of those where interpreters have to become involved. And that sets up a whole different kinds of scenario. And if you look at, here are some decisional conflicts, concerns about undesired outcomes, wavering between choices. And I heard from the questions that came in through, that Humera talked about that came in ahead of time, are decisional conflicts that fit for shared decision making, delay in the decision, questioning personal values, being preoccupied with the decision, showing signs and symptoms of distress, whether to participate in a research opportunity or not. And some of the examples of decisions are the clinical trial participation, medication options, wheelchair options. Is this time for a wheelchair? And it's a big change in that child and the family's life. Developmental transitions, surgical options, aggressive treatments, respiratory interventions, screening and diagnostic testing, end of life. These are all decisional conflicts. These are just some examples of decisional conflicts that we have experienced here and that I'm thinking some of the families who are joining us have experienced as well. With the next slide, because I know I'm trying to watch my time, is the referral process, because some of you are saying, okay, how does this work? We are working closely with Muscular Dystrophy of Canada, and there will be a referral process put in place for families so that it's easy access. So this is a process that I'm sharing with you that we use at Children's Hospital. First of all, it's important to know that anyone can refer. The family can refer themselves. We do require a family physician or everyone to make the referral to the lead physician, which is Dr. Campbell, and the decision coach, which is myself. All healthcare professionals are informed. So if you make the referral for yourself, or a family physician or someone else makes the referral, everyone involved in the family's care are informed. An information message goes out to let them know that a referral has been made, and this is the decisional conflict that we're working with. Evidence is gathered. Decisions aren't made, they're only supported. Again, I reemphasize that I do not make the decision. I only help facilitate the families and the healthcare professionals through the decision-making process. OTN in person, and urgent referrals we try to get them done. They can be done. We've done a couple within 24 hours as long as all the information is there. And you can see the referral process. It's a small print for you to see as well. But what I do is when I receive the information, how I contact the family by phone. I administer a conflict scale. There are about 4 questions, very easy to answer. I book the consult. The conflict scale really lets me know what you don't know. Is your knowledge, are you lacking in knowledge? Are you lacking in, support, decision aids? What is it that you're missing? And the AutoOff Family Decision Guide is used to go through the consult, which we saw that tool. And then follow up from that is I have another document, the satisfaction and knowledge decision scale, where we look at, was the consult helpful? Did you get the information you needed to make a decision? And evaluate the decision coach. Was that helpful? Would you recommend it to someone else? What was specifically helpful for you? And then a consultation report is prepared. And I wanted to also share with the next slide, I know that feedback, so how do we know this benefits families? I've captured some decisional coach feedback from some of the families. Everyone who gave feedback, not everyone wrote a little testimonial, but no one said it wasn't important and that everyone said they would recommend it to someone else. But here you can see Decision Coach was helpful in clarifying our options and in creating a plan for our appointment with the neurologist. I also appreciated the fact that she was completely unbiased to both opinions and options and doctors. She was completely neutral, so didn't pressure us in any other way. So you can see how that validated what I said, what the importance of decision coaching is. We found it helpful to devote some devoted time away from home to have formalized discussions about our goals. A couple who were very involved with their life, with their career, had a child that needed special attention and treatment, and they came together. When you're home and you're working, you're busy with home events such as your laundry, your school, everything that keeps your life together, and really to sit down and take time and devote time to discussing what the issues are, and important to weigh those decisions together. It's very key. This discussion was good. I really liked it. When the doctor recommended surgery for our son, we didn't know much about what it meant. Having received this information with the pictures describing the surgery, the risks and benefits, gave us a much better understanding of the type of surgery for their son. And then the next slide, it's continued. It was helpful to speak to someone else, not just your partner. One feels pressured when speaking to the physician. We got a lot of information to go through, made all the testing easier. We knew what to expect, what to prepare our child. It allowed us time to ask questions we thought of after we met with the neurologist. And after being put in the situation with our daughter, we were thankful to have guidance. Decision coach was knowledgeable and offered supportive listening, a lot of time to answer our questions, and requested additional information. And we do. Sometimes you have to go back a second time, and appreciated the helpfulness, and that's fine, Hamira. This slide, it's a poster presentation that I was putting together. It just kind of gives you the sense of the impact that we've had over the last 2 years. A patient revolution for careful and kind care. Couldn't say it better. You can see that we've had an impact on internal and external groups, our own colleagues here at Children's Hospital, in quality improvement, looking at the options and benefits. We've also provided parent education. We do have parenting education classes that we've started that help parents learn how to make decisions. We're entering new areas of expansion with our involvement with Muscular Dystrophy of Canada. We're looking at the London Foundation Court Clinic, or London Family Court Clinics, looking at cases, especially with COVID-19 and accessibility issues. I'm working with a couple of families on that, so that's new and expanded area. And we're also looking at research, doing a little more research now that we've got our feet on the ground and moving quite well. But I just wanted that diagram to kind of show you the impact that we've had. And here are some resources that I always like to show people, and I end. Thank you.
Thanks, Bonnie. A lot of good information. And we're so happy to be partnering with the shared decision-making project, with Danielle will talk about as well, in addition to the system navigation program here at MDC. Danielle is the director of mission with MDC and is a registered social worker. Danielle is a former Paralympic swimmer. She represented Canada in the Paralympics, winning a total of 3 golds, 2 silvers, and a bronze medal, and held at one time 8 world records. Danielle holds a degree in social work and is a certified child and youth worker. Danielle was invested with the Order of Ontario, the province's highest distinction. We're very happy to have Danielle on our team and here today to talk about system navigation.
Thank you, Humira, and thank you everyone for joining. I first want to say a special welcome to all of our service specialists that are on the call today, as well as my partner, Marie-Hélène Boldwick, who is here, the other director of mission. So we are very happy to be joining you today and talking to you about our system navigation program. Our system navigation program was piloted in 2012 in Ontario, and due to the program exceeding expectations, we rolled it out nationally in 2019. Our program, as you've heard, like all others today, is person-centered approach. Our focus is on the individuals, their families, and we know that we have different experiences and opinions from case to case. The system navigation program is innovative and creative, sustainable solutions that have a broad reach and a large impact, and that we are able to deliver in a cost-effective manner. Our program relies on partnership and technology so that all clients will have access to the system navigation program. It is our priority at Muscular Dystrophy Canada that no matter where you reside in Canada, we strive to provide a high quality of services, whether you are in a rural area and the hard to serve areas, or if you're in one of our major cities across Canada. So how does the system navigation program work? So this first step is that oftentimes people will go to clinics, hospitals, community organizations, and you'll receive information on Muscular Dystrophy Canada. And so it's a simple phone call to Muscular Dystrophy Canada. Sometimes it's through a self-referral, sometimes it's through being with your doctor and hearing about Muscular Dystrophy Canada, where a call comes in to MDC, and there you will fill out the application process. So our registration process, where you can find our applications, are also online. You register, become a registered client with Muscular Dystrophy Canada, and then you are connected to a service specialist. We have service specialists across Canada and that cover different areas. And so from there, we're here to meet and help to assess the needs and identify areas of support that we can help with. So our system navigator provides direct support in education, assistance with securing resources, awareness, emotional support, coaching, mentoring, and peer support. You can go to the next slide. Thank you. So exactly what does that look like? So oftentimes you'll be referred to, you'll come in contact with Muscular Dystrophy Canada, and it's the first time that you've made a call. So if you can sit and imagine that yourself or your son or your daughter are requiring a new wheelchair. And so the thought is, I'm going to call Muscular Dystrophy Canada and talk about the need for this new piece of equipment. So the phone call may come in to us for an equipment request. And as you'll see here, it starts with an equipment request, and we will work actively with you to help figure out how do we best support getting this equipment. Does that look like we are reaching out and contacting other organizations, other funding resources that we are aware of, helping you to fill out the applications? We know that across the country, there are many, many different applications, many, many different things where we need to gather the right information, gather the right things to be able to move forward. So a call may come in for an equipment request for a wheelchair, which quickly turns to the fact that there's some need for some emotional support. Are we ready? Are we able to cope with the fact that now I'm moving into a wheelchair, and what is life going to look like? Or is it that my son or daughter is now needing a wheelchair and we haven't really thought about this process, or what does that mean, and the grieving process, or the different emotions that may come up. Like I talked about with funding, your service specialist will help you to navigate the different funding resources out there. Muscular Dystrophy Canada does have an amazing equipment program. We are a last resort funding. And so what that means is we will search with you to look for the different areas that we can tap into to help make sure that we're providing you the most support. One of the very unique things to know about our system navigation program across our mission department is that we're not a referral program. So we're not going to take your call, take your question, and refer you to the right program. What we're going to do is walk alongside you. So if that means that today filling out applications feels overwhelming, then that's something that we're going to help do with you, or help to kind of do. I love the way that Bonnie said, Dr. Google, to allow us to do some of that investigating for you and to come back and to bring you the information that we found. Sometimes, like I said, it might start with an equipment request and it quickly moves into, we need to do some education in the school systems, education around how do we accommodate, how do we make gym classes more accessible, we have amazing programs like Muscle Facts, which will go into the school and educate the teachers as well as the students on what is a neuromuscular disorder and how and what does that mean. And when it's done in a really unique way that's not identifying so much the person that has the neuromuscular disorder, but how can we all kind of work together and make this a collaborative approach. At times there's individual advocacy that's required. So sometimes it might be that we need to advocate in the school system, like I mentioned. Maybe we need to send a letter to help get some additional funding in certain areas. Maybe it's about sending a letter so that we can help to access some accessible housing, or what that might be. So our system navigation program is really unique because we know that nobody's neuromuscular journey is the same. So what we want to make sure that is understood is that at Muscular Dystrophy Canada, your service specialist is there to answer the phone with whatever that might look like at the beginning of the phone call, and walk alongside you as we identify the needs or we identify the areas. And quite simply, sometimes that's just picking up the phone to say, I just need to be on the phone with someone right now that understands what muscular dystrophy is. I don't want to have to take the minute to explain the frustrations that we're going through right now and have to explain really what is muscular dystrophy, because my support system is great, but right now I just need to be able to be with someone who can just actively listen and empathize and help to understand, you know, what I'm going through, even just to give me that moment to process. And so that's what we really want to explain with our system navigation program. As you'll see here, we have our service specialists across the country here to help, both in English and in French. We know that across our country, it's not the same services within each province. So though we are a national organization, the service specialist that represents your area is very skilled in the services and resources that are available to you. And to what will help meet your needs. So funding that might be available in Quebec, that's not necessarily available in Ontario or British Columbia. We have our service specialists that specialize in those areas so that they can help meet our clients' needs. And so also we want to share with you the importance it is for us to just feel free to reach out, to know that we are here to listen and to help. Kind of walk through whatever it might be at the time. Recently with COVID, we heard the need for that peer support, that connection, and that networking opportunity. So we were very excited to launch our networks virtually and to move those forward. So I would encourage you to go online and see all of our contact information is on our website. You can see the numbers there. And if you get to the general area and you have a question, they will direct you to the right service specialist. So don't worry if you're not sure exactly what area you fall under. Within Muscular Dystrophy Canada, we are really excited, as you heard today, that we will be partnering with Children's Hospital, London Health Science Centre to do the shared decision making. So this is an amazing opportunity for us at Muscular Dystrophy Canada to be able to contact and work closely with Bonnie and just another level of service that you can provide. So again, on behalf of myself, Marie-Helene, and all of our service specialists, we thank you so much. And we look forward to talking to you and getting to hear your stories and help with your needs. Thank you.
Thank you so much, Danielle. I am mindful of time and know that we are at 2 o'clock, but I wanted to take a quick moment to let you know, Laura did a great job of mentioning that you can also be involved in research. There's very few studies that have documented how people with neuromuscular disorders can be involved with research or policy. There's this one study, which is a meeting report by Dr. Hans Lockmuller and his team from 2018. And really what's highlighted there is what Laura mentioned, in that you can help to inform the research. And that's what we have. There is an opportunity right now with Muscular Dystrophy Canada in terms of helping to tell us, how does your neuromuscular disorder affect you, impact you economically, in terms of financially? How does it impact you in terms of your everyday life? This survey is available in English and in French, and there's also an opportunity for you to be able to call us and say you'd like to complete the survey by phone. Participating in this type of survey helps us to inform our programs and services, back to what Stacy was saying, so that we can actually maintain and remain client-centered. It also helps us to take this information and help to advocate on your behalf when we talk to policymakers about access to drugs, policies related to this disability. So I wanted to really highlight this opportunity. And also I wanted to take some questions that might come through live, but Bonnie mentioned that one question that came to us ahead of time, and this is a common question that we receive as part of our research hotline, is a parent describing that their child has a neuromuscular disorder. In this case, it's Duchenne muscular dystrophy, and making the difficult decision in terms of which clinical trial is appropriate. So as Danielle and Bonnie mentioned, there is the shared decision making, there's system navigation that can help you with this difficult decision. The other question that's quite a popular one, we received it last week as well, is this feeling of anxiety over the decision of having your child return to school. This is a family that emailed us who is wondering if their child with SMA should return to school in the fall due to COVID-19, and whether they should seek homeschooling. This is exactly another example where system navigation and together with shared decision making can be a great program for you to be able to talk these decisions through and help to make an informed choice to help reduce the feelings of anxiety. Just going to quickly check the chat box for any other questions. Looks like they're mainly questions that are saying thank you. So today, to end today's webinar, I'd like to thank all of our speakers for sharing their insights, and to our mission team at Muscular Dystrophy Canada for their ongoing work with supporting individuals in our neuromuscular community. I also want to mention that one of the largest fundraisers for MDC, we are 100% donor dollar, supported by donor dollars. So one of our fundraisers is the annual boot drive by firefighters across the country. But unfortunately, due to COVID-19, we've had to take a lot of our events virtually, or we've had to go ahead and cancel or postpone. But it's really critical to raise these funds to continue to support our clients. So I really encourage you all to go ahead and to filltheboot.ca to learn more. I see a question from Will about the peer-to-support program. I'll go ahead and ask Danielle Campo to go ahead and respond to you directly. Will, thank you all so much for joining. Have a great day.
Hi, Will. Thank you for your question. Yes, at this time we don't have the peer support program like we used to in the past. One of the things that I would recommend you do is just join into our MDC networks that are virtually online right now. As you'll see, they are really kind of modeled after our face-to-face networks, as well as our peer support program that we used to have. So I would encourage you to join a network. And of course, if there's more of a need, of an individual need, please don't hesitate. You can reach out to me and I can definitely look at what you're looking for and how to best meet that need. So that is our 1-800 number. And also you can get in contact with us there.
Fantastic. Thank you so much, Will, and thank you, Danielle. As always, thank you for joining today's webinar, and a recording of today's webinar will be made available on our YouTube page. Have a wonderful day. Thanks, everyone.